Hi, I'm Dr. Kawita Bapat. Importance of BRCA test and screening in breast cancer for undergraduates, graduates, and practicing OBGYN. Important topic BRCA is, it's a long time ago. This used to be the story. A lady diagnosed with breast cancer, underwent mastectomy, chemotherapy being done, had side effects, recurrence, and expired due to the metastasis and toxicity. Breast cancer diagnosis tools such as biopsy, histopathological examination gave a basic understanding of the morphology of the tumor, but nowadays with ISC, cytogenetics, and molecular biology tools, it has revolutionized the way tumors could be typed and their biology better understood. Now the changing needs. Over the years, the laboratory medicine has evolved and targeted therapies such as MABs and TKIs have changed the way the patients have to be treated. Now, no more one-size-fits-all approach. Now, the changing needs and a companion of the diagnostics is basically the general medicine have been taken over by a precision medicine through targeted therapies. Targeted therapies are the work more precisely on the cancer cell, causing less collateral damage to the normal cell, and changing needs of the therapy have brought in a major changes through companion diagnostics. So the molecular biology, it also detects the underlying genetics alterations and responsible for the malignant conditions and the mutations. And it's aiding to the therapy. So the important point is in a changing needs, we only need not to diagnose the cancer, but we should be able to diagnose the type of the cancer, and all the targeted therapies and the molecular biology should work on it. Now the story continues. Few years later, another lady diagnosed with a breast cancer undergoes surgery, tested for HER2/neu, then undergoes targeted therapy, faced lesser side effects, and had a longer survival. Now, what has changed basically? A sad story continues. Few years later, diagnosed with a breast cancer, she has a questions in her mind. Two questions in her mind. Number one, what are the chances of my daughter getting breast cancer, and can I avoid chemotherapy? Now, the question one, possibility of daughter getting a breast cancer, and number two, can chemotherapy be avoided? Very, very basic question. And for possibility for daughters getting breast cancer is a testing, that's a BRCA1 and BRCA2. And for can chemotherapy be avoided, we need a genome testing. So the germline genetic testing as an individualized care, risk assessment, disease prevention, and therapeutics. The BRCA1 and BRCA2 as the prototype. BRCA1 and BRCA2, the proportion of the cancer is very, very important. The population risk with the breast cancer is 1 in 10, ovarian cancer 1 in 100. So see the difference. Inherited susceptibility to the cancer in a genetic is a 5 to 10%, but it's only by a single gene. Number two, family history of a cancer, familial, 10 to 15%, question mark, that's a multifactorial origin. Number third is, there are many times we see the cancers with no family history of the cancer. It can be a sporadic and it accounts almost 80%. So there is a genetic overlap. Sometimes the having a multiple genes can increase the risk of single cancer, or sometimes the multiple cancers can be associated with a single genes. So the hereditary of the breast cancer, current view of HBC etiology, 25% is BRCA1 and BRCA2, 5% rare high-risk genes like a PTEN, STK11, and CDH1, and 70% is a combination of low but a common mutation and a moderate risk of genes ATM, CHEK2, PALB2, BRIP1, and RAD51C. So only less than 10% for all breast cancer. Now the why to test the BRCA, BRCA. BRCA care in a lifetime, 35 to 80% and a 12 to 13% is a general population. It's a 12 to 30% and a BRCA mutation carrier are 35 to 80%. Ovarian cancer in a lifetime, the BRCA mutation carrier can have 40 to 60% chances of ovarian cancer. In a general population, only 1 to 2% women. And in a men, there can be a breast cancer lifetime BRCA mutation carrier 5 to 10% and other cancers in a 0.10 10%. Now, why test the BRCA? BRCA is associated with a lifetime risk, breast cancer, secondary primary breast cancers, ovarian cancers, and possibility of the increased risk of other cancers like a prostate and a colon in men and female colon also. BRCA2 is associated cancer risk lifetime, breast cancer 50 to 85, milk breast cancer 6%, ovarian cancers 10 to 20%, and increased risk of prostate, laryngeal, pancreatic cancer, its magnitude is unknown. Now, why should undergo BRCA1 and BRCA2 testing is just like why we want to do is there are many guidelines. The NCCN guidelines, the BRCA guidelines, and therefore the breast as well as the ovarian cancer. And they have a list of things, the criteria, what the individual family, diagnosed less than 45. If diagnosed more than 50, there are many more criteria that should be followed. Now, what is the high risk for the BRCA testing? 2 first-degree relative or 1 first-degree relative and 1 second-degree relative with breast cancer, average age less than 50. 3 or more first and second degree relative with breast cancer at any age. 1 first degree male relative with the breast cancer at any age. 1 first degree relative with a bilateral breast cancer where first primary diagnosed less than 50. 1 first and second degree relative with the ovarian cancer at any age, and then 1 first and second degree relative with a breast cancer at any age. Women with a Jewish background should also be tested. Now, what is the moderate risk? 1 first degree and a second degree relative diagnosed before the age of 40. 2 first degree relative or first degree relative and 1 second degree relative diagnosed after the age of 50. So, this is a breast cancer study which we should follow. The moderate risk, 1 first degree and a second degree relative diagnosed before the age of 40, 2 first degree relative diagnosed, 1 first degree relative and 1 second degree relative at the same time of the family diagnosed after the age of 50. See, this is how we can tell about the male and a female. Female is having a CA breast diagnosed at the age of 54. She is having 2 kids, 1 male and 1 female. Now, there is a CA breast diagnosed at the age of 52. The mother is also breast cancer and the daughter is also having the breast cancer at the age of 52. Married to a person. They have 2 kids, 2 females, and at the age of 20 years, one is 20 years, and we should be the patient requesting the screening considering the prophylactic mastectomy. What is her level of risk? What is the appropriate management for the risk? And patient is also interested in genetic testing. Can this be offered? So, if the mother is having CA breast at the age of 52, as well as the grandmother is having the CA breast at the age of 54, both the daughters should be tested for the BRCA. They are the cases of moderate risk. Now, the breast cancer study, another. So, if the female died of a CA breast at the age of 40, she is having 2 daughters. Another, her brother's daughters are also having CA breast, and she is also having a daughter. So, should we consider the prophylactic mastectomy? For example, these are the brother and sisters. The sister got the CA breast. She is having the 2 daughters. Brother's daughter is also having a CA breast at the age of 32, and her daughter, what should be the family offer? So this is the another study. The another study is very important. A CA breast died at the age of 40. She is having 2 daughters, recommended screening. Her brother, again, brother's 1 daughter is having CA breast, and her another, and then the child of the girl child of that female, what should be done? This recommended breast screening is done. Another study we can say, a female having a CA breast died at the age of 40. She is having a daughter. She also diagnosed at the CA breast at the age of 35. Another daughter not having anything. Her brother's daughter again having a CA breast. And what about her daughter? So it should be offered the CA breast diagnosed at 32 and testing ongoing. So they all need, all patient needs a CA breast BRCA testing. Another CA breast died at the age of 40, having daughter, CA breast diagnosed at 35 years. Another daughter, no cancer. The brother's daughter is having CA breast and found a mutation. And what about the daughter? Should be prophylactic things should be done. Another case is like this. This is a case of CA breast died at the age of 40. She is having a daughter, CA breast diagnosed at the age of 35, BRCA mutation carrier. Her sister is also having a BRCA1 mutation carrier. Then her sister's daughter is also having a CA breast and mutation has been found. So this is the management thing. What are the average risk? Ovarian cancer, 1.2%, breast cancer, 10%, moderate risk. About the high risk, BRCA1, BRCA2, breast cancer, 50 to 85, secondary primary, 40 to 60%, and ovarian cancer, 20 to 50%. So breast tissue, awareness for the clinical breast examination, every 3 years in 20s and 30s, annually beginning, and the mammogram, 50 years annually. Moderate risk, again, breast tissue, and awareness about the clinical breast examination every 6 months, mammogram once at the age of 5 to 10 years before the breast cancer in the family, role of MRI, 3D mammogram, option chemoprevention, tamoxifen, raloxifene. Then the high-risk patients, self-breast examination monthly beginning at the age of 18, BRCA testing, clinical breast examination every 6 months, beginning from the age of 25, mammogram and breast MRI annually, age 25, risk-reducing self-oophorectomy at a completion of childbearing, transvaginal ultrasound, CA125Q 6 months, risk-reducing menastectomy, chemoprevention, tamoxifen, raloxifene, aromatase inhibitor. Now, what is the genetic testing? Shows an increased risk of a cancer. If genetic test results positive for a gene mutation, chemoprevention, prophylactic surgery, changes into the lifestyle, cancer detection test, and the self-breast examination, mammogram, MRI, and screening of other relevant family members for the same mutation. Now, what genetic testing looks specific inherited changes in a person's chromosome, genes, and proteins. Genetic variation can be harmful, beneficial, and neutral. Effect on mutation, wild type. The cat sat on the mat. Substitution is the rat sat on the mat. And insertion single gene is a cat spat on the mat. So these are the problems with the sickle blood cells and a normal blood cell. And these are the problems with their having the effect of mutation. Now the BRCA1 and BRCA2 gene, these are the chromosome 17 and a chromosome 13, BRCA1, and this is on the 13 chromosome. So the protein, there is a sequences are different and a color over there, and GATC are the nucleotide that make up of DNA, and this is the thing. So the BRCA1 and BRCA2, BRCA1, 2 DNA repair, cell cyst arrest, and cell death. And this all three leads to genome stability. This is a BRCA1 and 2 mutation. So the problem of missing protein or a non-functional protein. Now, what are the drawbacks of the genetic testing? Genetics testings do not have precise answer about the inherited disease, especially about the breast and a colon cancer. A positive test result does not always mean you will get the disease. The test will tell what might happen, but it cannot tell what will happen. On the other hand, negative result does not mean you have no risk of getting the disease. In case of negative result, there is a possibility of having the mutation in the other gene that has not tested. So there should be the multi-gene testing for the inherited cancer and next generation sequencing. This is the latest things and we should go for it. So this is called a multi-testing gene. And another reason to consider, update additional genetic testing, a change of personal cancer family history. This is a new diagnosis. So there is a multi-gene panel. So many genes are being tested and we have to find out. Now the levels of BRCA1, 2 testing are available. Complete sequencing by next generation sequencing, comprehensive, and a sequence analysis, both common and family specific, get covered. BRCA1 and BRCA2 analysis by MLPA for deletion, dupletion, and large rearrangements. BR complete NSG panel, that is BRCA1, BRCA2 plus 10, next generation sequencing for extended panels of gene associated with the breast and ovarian cancer, and additional markers are also needed. They are mama print and a blueprint. So the breast cancer addressed two important questions: risk stratification of metastasis and balancing metastatic risk with a therapy. Testing tools commercially available like a genome assay, mama print. So there is a 70 gene expressions, 7 genomic pathways, and 2 categories of the risk, and validate all those things. But what are the recommendations? The patient has the hormone receptor positive, human epidermal growth factor negative, node negative breast cancer. Mama print assay may be used for all those things. So this is on the blueprint and a mama print. This is a latest into the BRCA testing. We should consider all those things for the chemotherapy, for the treatment, and for the survival. Now the conclusion: genetic testing can be very useful for the patient and their family members. Genetic testing is a continuously evolving. BRCA1, BRCA2 mutations are most commonly found and we have reasonable data how to manage. New genetic tests are often less clear in terms of how to change patient's care and improve patient outcome. Variants of unknown significance should not be managed as a mutation. In the phase of rising prophylactic mastectomies, we need to emphasize patients how mutation in these genes are different from those BRCA1 and BRCA2. Thank you so much for the patient listening, but the take-home message is when you want to get the test BRCA1 and BRCA2, we should consider the clinical examination, we should consider the self-breast examination, and we should consider the regular checkups with a little lifestyle modification, and all those things are very, very necessary. Thank you so much once again for Learn Simply. Thank you so much.